Thank you. So these were terrific talks. Thank you very much. I'm really lucky to be here today. One question for Peter and one for Dr. Vargas. So Peter, the genomic post-diagnosis assays and markers, of which there are, half a dozen or more now, a lot of these were validated only on men who had an intervention rather than men who had a long history of the natural history of the disease. So in other words, if we look at the outcome, it may be that that man had features of lethality, but the interventions actually cured them. So how do you reconcile these issues?
So it's a great question, because we see the adverse genomic score in the face of an undetectable PSA, and usually in those cases the undetectable PSA trumps the adverse genomic score. I think what we're moving to is a predictive biomarker at the time of diagnosis to determine treatment. So again, I think these post-diagnostic markers are somewhat informative, but actually not enough to make us act in the face of what appears to be a good clinical response.
Great, thank you. So the other question was about radiology. Big hype on radiomics and radiogenomics. Where do we sit, and what's the future of radiomics? It's words that have been used. There are quite not many papers, but a few publications to suggest that with radiomics one might be able to determine the aggressiveness of the disease, looking at the features, and that needs to be linked to genomics as well to produce this magic radiogenomic score.
Alberto is not here in the room. I'll talk about some of the studies we've been working together on. So we've been trying to combine a lot of the MRI data with some of the current assays that we have in genomics. And to be honest, the correlations and how we look at it, it's not very clear. The primary issue being, what is our outcome measure? We've always fallen back to pathologic outcomes. And as Andrew has shown in the past, some of these outcomes are woefully weak as far as determining long-term outcomes.
The other thing that, and we've been doing MR at UCSF for 20 years, been continuously funded. As Alberto mentioned, you have a test which is a high-tech test, 5,000 images, complex data. It takes them a couple of days to get the result, and you plop down that image in front of a radiologist who gives you a score 1 through 5. And to me, we're missing data there somehow. And I think this is a big interest in people like Google Health and others who are going to take this to the next step and understand these images better. So in my extent, we need to get more information from the images that we're currently getting, because right now they don't correlate well with, at least when we look at it, the PIRAD, if you go PIRADs versus genomics, very poor correlation, yet both are predictive.
This is a question for Dr. Vickers. Was the data on which your screening recommendations based, did that include enough of a diverse population that these recommendations can be applied to high-risk populations such as African Americans?
Yes, it's a great question. A lot of screening recommendations there, so I have to try and pass them out. So one of them is, one of the things that we've been quite critical of is a lot of the guidelines say, start screening at 50, but 45 if you're an African American. And our guidelines say start at 45 with a PSA. Once you know somebody's PSA test, that is far more powerful than anything like family history or race. So, the relative risk we're talking about for African American is, people say it's 2 or 2.5. For having a high PSA, the relative risk is, 7 or 10, something like that. So, and there's also very good data that the prognostic value of an early PSA is completely independent of race. So that's been done in African American populations. As regards to the biomarkers, I don't know about PCA3 or PHI, but the 4K score has been independently validated in African Americans and works as well, if not better, in that group. So in the MSK guidelines, we have not made a distinction based on race. What I will tell you is the effect of those guidelines will be to shift screening from older whites to younger African Americans.
Neil?
Good morning. I'd like to ask a question of Dr. Mao. The one herb that you didn't mention is the one that my Prime Minister, Trudeau, who has hair sort of like Andrew Vickers, is espousing, which is cannabis. So we have a massive legalization effort right now in Canada, and we've actually been doing some work with cannabis in patients, particularly on hormone therapy, and I wonder if you have any insights around the use of cannabis for patients in the prostate cancer spectrum.
That's a really great question, a kind of politically sensitive question. I think just in my work in the field of palliative care and symptom management for over 10 years, I'm both optimistic and, but also feel like a lot of cannabis, it may be hypes. So I think we need to be sort of slower than, say, the public want us to be. And I feel like for people with advanced cancer who are experiencing nausea, fatigue, weight loss, and unmanageable pain, I do think cannabis is likely to have a lot more benefit than harm. But in the clinic, I also get to ask people really pretty well, and if they just be physically active, do yoga, they would be fine. They say, oh, there's cannabis, should I do it? My gut feeling in the survivorship context, I feel like this is, my gut instinct, this could be just the next opiate. And I just think we just have to be careful. And because it is a powerful agent affecting our central nervous system. And I'm a strong believer if we want to have the most healthy central nervous system, that should be the one that is independent of substance.
My question for the panel is one of guidance for the medical oncologist. We often see patients who are coming in with Gleason 6. They come in for a second or a third or a fourth opinion if they haven't already gotten started on hormones inadvertently. But, excuse me, for many of them who have Gleason 6, sometimes you'll see a 5+1, maybe 2 cores, 3+3, 5+1, not more than maybe 10, 15%. And the question we, as oncologists in the second opinion setting, have been asked is, should I stay on surveillance? Do I go to surgery? What do I do? Now, I think Drs. Fine and Ehdai came up with excellent points regarding, well, we should look perhaps at genomics. Maybe we should look at other, the percentage of the core, et cetera. But we are very unique here in that we're able to do that, but for the real practitioner who might be in the community or somebody at a lesser non-cancer center, what do we tell people? Because people are still relying of, oh, that's a 5+1, that guy's got to go to surgery tomorrow, versus, waiting for the genomics to come back, because obviously a lot of institutions are not in real-time genomic profiling. So I think, is there something that could be put out to other people who call us regarding some of these cases that we can, as a general recommendation for what to do with these people when they come in?
That sounds like a whole day answer.
I'll take 2 answers.
Yeah, so I just wanted to mention,
Yeah.
in case this wasn't evident, in the tumor quantification realm, really, with the exception of the %4 discussed, which is now not just recommended by the WHO, but is in the College of American Pathologists required data elements in their recent update in early 2017. Meaning if you want to be CAP accredited, which means you want to be credited by the American College of Surgeons today because the two are linked, you've got to be reporting this. That's a newer factor past 2-3 years in this institution, for instance, and in multiple other institutions. But the rest of it, in terms of tumor quantification, has largely been in pathology reports for 10+ years. So those measures, and which ones are the most robust, at least from the pathology perspective, should be readily evident in the community. We don't read a report from the outside that doesn't give us a percentage, and usually a millimeters too, which is helpful because you can get an idea of what the real volume of disease is, which percent alone might not give you. And now the question is how to add factors in that regard. Very few of them have been taken into account systematically in designing models.
If I could just mention, so generally Gleason 3/3 is a candidate for surveillance. One thing I didn't point out is that one of the strongest predictors for treatment on surveillance is PSA density, so the PSA divided by the gland volume. And every time we look at our outcomes, and we have a large active surveillance population, it comes out on top. So PSA density below 0.15 is important. You have to have good pathology review. I do think that adding genomics is helpful. These are standard commercial tests. And I would do an MRI because you're trying to determine whether when the patient needs a repeat biopsy. So we would, expert pathology, good biopsy, Gleason 3-3, we would add the MR. Add the genomic profile.
And one brief just observation, a comment and then a question, then we'll go to break. All of these items, the additional genomic measures, imaging measures, we get hints can make a difference. But it's probably in the ether as to whether or not it reduces mortality in a patient population that's being tested and treated. Maybe for Dr. Fine, one last, take us home, please. I think your great two examples of both group 3 were classic. I know Peter, if Peter were looking at both of those pathology reports, it's almost the Supreme Court definition of pornography. How do you define it? Like, how do you define a bad cancer? You know it when you see it. Are we really helped in terms of clinically, the clinician in the audience here who's looking at a grouping, when we group information together and take away some of the granularity? These are for reporting purposes, obviously, but what's the message for the clinician in terms of the grouping?
And so I think the value in the grouping is the very clear delineation. These groups are, even according to all current recommendations, very much based in the morphology of Gleason, in the notion that we haven't gone away from that. However, the notion of 3 + 4 = 7, for instance, versus 4 + 3, which might seem more granular, okay, was clearly not, because up until about 2010, most clinical studies grouped them as Gleason 7, when most people seeing high volumes already knew these were different disease. Now we've sort of said, okay, let's clearly separate them so that there's no ambiguity there and the like. So I think that's one thing in terms of morphology. Beyond that, looking around just in preparation for today at most of the predictive clinical pathologic models, and maybe because different centers have done things differently, but now some of these measures are routine across centers, as mentioned, the lack of standardization and the inclusion of the quantitation into different groups, these % of pattern 4 and stuff like that, has hurt us, because we might be able to garner a lot more, like we have PSA and then a 4K score, from good laboratory data, good pathology data, good clinical data, that we might not need to jump so far to things that we don't know their prediction of real outcomes.
Terrific. Please join me with giving a round of applause to our panelists. And we will come back at 5 minutes after. We'll take an additional 5 minutes. Please come promptly, because Dr. Lin will be moderating the localized prostate session.